in the Houston area. There's 120 clinics spreading about a 3-hour drive east to west and an hour north to south. I was over patient experience there. We had a ton of success. In a little over a year, we moved from the 47th percentile in the country to the 74th. Prior to that, I was actually, I had a few roles at UT Physicians, but also worked for a while at United Surgical Partners International, managing surgery centers and surgical hospitals. So yeah, I'm very pleased to be with you all tonight and talk about this subject. I'm passionate about it. I will give a brief disclaimer. Some of the information I'm going to present comes directly from Press Ganey. Some of it comes from things that we did down in Houston at UT Physicians, and some I've honestly just stolen from elsewhere. So I list my references though at the very end, so you have those resources. In fact, one of them is a report that I would very much advocate everyone take a look at, read through. It was done by the Kentucky Department of Public Health, outlines some of the large-scale areas of improvement that we'll talk about tonight, and the initiatives that they have going forward to help from the government side of things. Okay. So some, if not most of you, have probably, okay, well, have probably seen this already. I'm going to show it anyways because it gets us in kind of the right frame of mind. Everyone remembers Maslow's hierarchy of needs. That very bottom layer to the pyramid is I need safety, right? I need physical protection. So when we're talking about someone's health, obviously homelessness is a problem everywhere. But they need that physical safety. They need to live in a home. But sometimes that's not even enough. So this example I have here, the 2017 UK Grenfell's Tower fire. So this was a fire that happened in a housing project in the UK in 2017. The design of the housing project was outdated and actually facilitated the spread of this fire throughout multiple buildings. So 71 people died for something that was definitely preventable, but that physical safety was not there, right? You have sanitation, electricity, clean drinking water. These are very basic things. Public transportation. Why is that important? Get your appointment. Get your appointment. Maybe get you to a higher paying job or access to higher paying jobs. Access to places where you can have physical activity. Services and network, higher paying jobs, parks, higher education, healthy food, health services. And one of those things being areas that foster physical activity, we're looking at parks, sidewalks, hiking trails. It's hard to, we talk about physical activity as a choice. You need to get up and go to the gym and whatnot. It is very hard to get up and exercise when you do not feel physically safe in your neighborhood. Am I right? None of us want to run on those streets, including people living there. Green spaces. Green spaces, for years, research has shown that these have a huge, very powerful influence on our overall health. The competitor to green spaces is built environments, so living in like a downtown area where there's a lot of concrete and asphalt involved. Green spaces are very positive influences on promoting the health of populations. We're looking at neighborhoods, towns, cities, states. Access to healthy foods. So I'm going to tell you a little bit of a side story. So in my previous organization, at one point in time, I was over the development of an entirely new medical home. So I didn't do the construction side, but I had to make sure that all the right people were hired. They went through all the appropriate trainings. We had built our contacts with the police department, the fire department, this sort of thing. And I'm driving through the area trying to find, where can we refer these people when they need to see specialists. So it's largely primary care, OB-GYN. There was going to be some specialties, but certainly not enough to handle all of the really big 5 chronic diseases. And as I'm driving through this area, it's surrounded by 3 highways. So if you take a look at my hands, this is kind of what it looked like. The clinic in this neighborhood being right in the middle. People don't tend to cross highways. They serve as huge barriers to not just care, but obviously access to healthy foods, access to parks and places that foster physical activity. And there was actually some really ugly bank policies back in the 1930s that promoted segregation via highways. So anyways, I'm driving through this area, and we're looking at making this place, this entire neighborhood of Houston, a healthier place to live. They do not have a single grocery store within those 3 highways. When I drive, I think it was 7 miles up, not one grocery store. The only access to food was a convenience store, unless they crossed the highways. So that's a prime example of food desert. So the access to healthy foods is not available. I don't want to say opposition to that, but similar to that, the food swamp would be living in an area that has a very high prevalence of fast food. And that is the primary option. There are no healthy grocery stores available. It's really just your McDonald's or Burger King, that sort of run around. Community gardens are an excellent way to combat both of these situations. So I'll talk about this a little bit, but we actually built clinics and added to clinics community gardens on the outside. We would have classes to teach people how to use them. They're usually free. People are able to plant and pick as they choose. My dad actually has Texas as well. So these are a great way to get people both physically involved and also access to healthy food, which we know oftentimes is not so affordable, right? And then access to health services, obviously, huge in terms of infrastructure. When we say access to health services, we're not just saying is there a clinic nearby, but do I have health insurance? Can I get health insurance? Can I afford it? What does that look like? Socioeconomic environment. So starting off, we're looking at the labor market. So when we have unstable, or when the labor market tanks, we get this unstable social environment. That leads to social disorganization, an increase in crime, higher rates of PTSD. Think of 2013 Detroit. I actually went there in 2013. I was meeting with some surgery centers that were outside of that area, and I heard so many stories about what Detroit was going through at that time. And so I went downtown to kind of see it for myself, and it was, it was rough. The skyscrapers kind of, for lack of a better term, look like crack houses. The downtown area, I remember there being a road that bordered the water, so you can see Canada on the other side. It's 3 lanes going in each direction. I stopped in the middle of the road at 6 o'clock on a weeknight and take pictures because there's no one behind me. There's no one for several minutes. It's that deserted. But these are the things that happen, right, when the local economy tanks. We have really poor design for fostering good health. Community institutions, social environment, neighborhood. So these are linked to physical health risks like smoking, obesity, low birth rate, which we know has huge implications for health moving forward. So when we have positive social environments, those foster social capital, leads to an increased safety and emotional health. So a good story to think about here is the combination of earthquake, tsunami, and risk of a nuclear meltdown in Japan in 2011. Most of these survivors of that event will tell you that they feel that they lived because of the relationships with their neighbors, their families, their friends that were nearby that came and helped them and got them to safety. But obviously, if you live in an area where you don't have that social capital, that mitigates your health overall and mitigates your safety. And in so many ways other than this too. I was in Houston, living in Houston during Hurricane Harvey, lost apartment and both cars. And it was the local community that really came together. To be honest, it was guys in trucks. There was someone posted on Facebook afterwards, Houston should resurrect a statue of a random guy in waders with a truck, because those people came out full front and helped people get in their apartments, get their belongings, help them get out other places. So that was huge to see. But obviously, if you don't have that sort of social environment in your area, those sort of behaviors don't occur in the first place, right? Social contagion. So this is the idea that we all influence one another, right? I used to tell this to staff doing new employee orientation down in Houston. I would say, look, I understand sometimes you're not having the best day. Your morning's already rough. If you need to sit in your car for a couple minutes and listen to your favorite song on the radio and turn up full volume, by all means, please do so. Just get yourself in the right headspace so that when you walk in, people don't need their morning coffee. You're going around, you're high-fiving everyone, you are that coffee. So this is the idea that, there's never a point in time when, as long as I'll be standing up here and you'll be out in your community, that you're not positively or negatively influencing your environment. It's never neutral. We're just moving in one direction or another, slightly greater, given what we're doing. So this is the idea that we serve as conduits to spread ideas, behaviors, lifestyles. This is huge. 32-year study of 12,000 people. This was published in 2007. They found individuals are 57% more likely to become obese if they have a friend who is also obese. Similarly, the likelihood increased to 171% if both parties considered one another friends. And what's kind of scary about this is physical distance did not play a role in that relationship. So whether you're states apart or you're down the street, those friendships mean something to our overall health. Also, it's theorized, there's research going on about this, that there's maybe similar relationships between smoking, depression, and sleep loss. Loneliness, this one is fascinating. Loneliness actually fosters a lot of poor health behaviors. In fact, I have a whole slide on it. So the mortality risk comparison, loneliness, when we compare it to drinking and smoking, relatively equal mortality risk. In fact, it's greater than obesity. Why is that? Loneliness results in increased risk of decline mobility, physical frailty. Also, some of the reasons that people become lonely, actually, it's a vicious cycle. So here are the high-risk populations. So the disabled, the elderly, those are the two that I'm lonely because one of these is the point I'm at in my life. I'm at this point in my life, or I'm in this state because I'm lonely. It serves as a cycle. And so this is your patient population that when they come to see you, they really need that personal connection. They need that, I'm preaching to the choir here, right? You all know how it is. When you have a Medicare patient come in, you may be the only person they talk to that day, right? That's the big thing on their calendar, is they're coming in, they've got a doctor's appointment today. And maybe they're not the only one, but certainly just from not being in the workforce, the amount of social networking and contagion that they're experiencing is diminished, right? So these two primarily are really good targets. Opioid users and other addicts. This is a tough one. This is one that is state specific to Kentucky, unfortunately. Opioid users they're in this state of not getting the social support that they need because they're viewed as criminals in our society, right? And in reality, they're one of the populations that need that social support the most, and to not be marginalized, but to actually be sort of brought in and accepted and talked to as you and I would, right? LGBTQ community as well. In case you're not familiar with the Q, that means questioning. Really, immigrants, minorities, high school dropouts, economically disadvantaged, really anyone who could feel discluded from the majority run a risk, but these are the primary target audiences. The UK actually has a really interesting approach to this. In 2018, they assigned a Minister of Loneliness to reduce social isolation. So the entire role of this position is to help build communities that are constantly in contact with one another. They have programs where they're meeting with one another, they're not in isolation, they're getting people out of their houses and integrated in the community moving forward.
An angel. Little girl?
Yes, sir.
I want you to do something very important, all right?
Okay.
I want you to run home, and I want you to call the ER of North Bank General Hospital, 932-1000. Tell them to set up OR6 immediately and contact anesthesiologist Isadora Turek, 472-2112, beep 12. Have them send an ambulance with a paramedic crew, light IV, D5 and W, KVO. You got it?
ER North Bank General Hospital, 932-1000, set OR6 contact anesthesiologist Isadora Turek, 472-2112, beep 12. Ambulance with paramedics and light IV, D5 and W, KVO.
That's good.
Sounds like a subdural hematoma to me.
Oh, it does it? Well, it's not your job to diagnose.
But I thought...
You thought, just go!
3 years of nursery school and you think you know it all, but you're still wet behind the ears. It's not a subdural hematoma, it's epidural. Ha! God damn, that makes me mad.
But obviously, behavior like that can foster loneliness, right? Not feeling included in the team. It's actually couldn't have been better timing. On my way up here, I was listening to the radio, and they were talking about the opioid epidemic that Scotland's facing right now. And there was a PhD researcher on the radio station talking about what's going on with them. And she actually pointed to one of the main causes of the opioid epidemic there was adverse childhood experiences, which we'll actually get to a little later. Here we are right now. So these are Kentucky specific. The Department of Public Health, this is what they're trying to tackle. And they've identified here are the variables that come into play, the associated risk factors with each of these areas. So we're looking at substance abuse, smoking, obesity, adverse childhood experiences, and integration into health access. And so we have some kind of somewhat vague identifiers for, well, what determines if someone's at a higher risk in this area. So I went through and read through the reports and tried to make that a little easier on you all today. So for smoking, Black residents of Appalachia, residents with adverse childhood experiences, LGBTQ community, low income, and education. For obesity, we're looking at mostly Eastern Kentuckians, any residents with intellectual developmental disabilities, Black and Hispanic residents as well. Adverse childhood experiences, if there's drinking in the household, there's substance use in the household, domestic violence, mental illness in the household, incarceration of a family member, or if they're a foster child. Opioid users, well, this is actually substance abuse, so opioid users fall on that. Here, northern and eastern rural communities are very much at risk. Any low-income populations, patients of providers that are not using naloxone or offering alternative non-medical interventions, and those who have poor access to methadone therapy. Methadone therapy is kind of still being spread out. It's not as widely used as it should be because there's a stigma attached to being an opioid user, right? But it's certainly a service that would benefit the population as a whole. And then access to health services on the far right. So residents without health insurance coverage, residents earning $25,000 to just under $50,000 annually, and also Kentuckians without a high school diploma. Any questions over this? No? I'm throwing a lot at you. I promise we'll get more specific on what can I do. So here we're going to start at the organization level. So this holistic approach to healthcare. These are some of the things that we did down in Houston at UT Physicians. So we actually set up these medical homes. So we took our primary care clinics, we expanded them, and we actually built a few new clinics in areas of town that had poor socioeconomic. So what do these clinics look like? Well, they had adult and pediatric primary care. They've got OB-GYN, behavioral health. When I say behavioral health, I'm talking psychiatry and counseling, both for adult and PD populations. Specialists for the major chronic conditions, cardiology, endo, rheum, pulmonology. But I'll be candid with you all, so you don't make the same mistake. Pulmonology is very difficult in the medical practice setting. I don't want anyone to make the same mistake we did. It's they're very expensive. They're very, very hard to recruit for that sort of position. Most of them want to go into sleep studies or stuff that's on the acute side of the house. Obviously, we wanted them to help us tackle COPD. That was a huge challenge and took a lot of time recruiting to get the right people and make sure that they fully understood what we were trying to do here. Dietitians that actually offer what we call food prescriptions. So these are healthy groceries for those who are financially qualified, and we partner with a local food bank to help us with that. We had certified diabetes educators and financial counselors. So our Financial assistance plan was largely stolen from the guy nicknamed Mattress Mac in Houston. Mattress Mac owns Gallery Furniture. He is very, very successful in Southeast Texas. His entire business model was that, so historically, these furniture outlets said, you know, we can't sell to those who are really below middle income. They don't buy furniture from stores like ours. And he says, no, they will if you have the right financing in play. So instead of saying, we're going to send you with financing and you have to pay, it's $250 a month, it instead became $50 a week. And that's something that people could wrap their arms around and could hold themselves accountable for. Is all right, I have these weekly smaller payments, it's the same amount. And so we actually did that in our clinics as well for those who qualify for financial assistance. This is one clinic, but this model is very similar across multiple UT Physicians clinics. So this is the medical home model. So the idea that you don't have to go, when you get referred to a specialist, you don't have to find their location, drive to that place, figure out what traffic's going to be like, or how am I going to get there, that sort of thing. Everything is in one location. We also integrated care teams in these medical homes. So this is a team led by a nurse case manager, and then it's a social worker and community health worker. Community health workers are people who go through I can't recall, it's either a 3 or 6 month educational program where they really learn about what are the shortcuts I can take, what are the resources I need to be aware of to make my life a little easier, to make the lives of patients easier. So it's either it's knowing where the train goes, where the bus route goes, what time it picks up, how can I get short-term living assistance, how can I get groceries for my children, that sort of thing. So they're very well trained, huge resources to the institution. And then these educational classes. So we would have, I mentioned the community gardens earlier. There would also be an activity room. In these activity rooms, we would set up classes that were specific to that unique community. So one part of town is known as the International District. I love going there because I love food, and there's great food over there, frankly. All the street signs for about a mile are written in Vietnamese. It's a huge Southeast Asian population, so we offer Tai Chi classes there. Also yoga, but yoga is offered at other clinics as well. There's diabetes self-management classes. There's classes on leveraging available resources. So it'd be one of those community health workers coming in and telling patients, okay, this is your problem. Here's what you should consider doing, right? One of the things we did that's not on here, I don't want anyone else to make this mistake. We actually installed kitchens in these rooms as well. The idea being that we would set up these healthy cooking classes. And to be frank, there's no evidence-based research behind those interventions. And that research, the outcome of that research supports what our experience was as well. Just not as well attended, not the outcomes that we were looking for. The other classes were much better though. So improving access to care. So working under this medical home model of everyone in the same facility, and if you can, put these in underserved communities. And these are places where sometimes primary care is there 2 days a week, and then when primary care is not there, it's cardiology or whoever it may be, OB-GYN, pediatrics. And so there's room sharing involved. There's specialties offered that are specific to that community. And then telemedicine may be necessary. That's something that we were starting to flirt with. I know University of Louisville and University of Kentucky both have some telemedicine programs in play as well, in case you're looking for resources there. What I want to do here is just sort of highlight, if this is a route you want to go, I want to make it as easy as possible. So just kind of telling you how we did it. So we extended hours of access as well, so we have better access to care. What that looked like was at least 2 times a week at this particular clinic, was 3 times a week. We had hours going from 8 to 7. Not everyone can get there between the hours of 8 and 5 Monday through Friday, right? Especially if you have a job that maybe doesn't offer paid time off, and that's time out of your paycheck. You don't get the health care you need, right? So the way we did it is clinics open Monday, 8 a.m. to 5 p.m., Tuesday, Wednesday, Thursday, 8 to 7. Friday it was back to 8 to 5, and then Saturday from 8 to noon. And you might say to yourself, well, how do you do that with the staff? How do you make that work? So this was the schedule. Those staff who were working the late hours and the Saturday morning hours would come in at 10 a.m. Instead of 8 on Monday. They work till 5. They work all Tuesday, Wednesday, Thursday. That's 10 hours, but they're off completely on Friday. And then they come in Saturday and work their 4 hours and they're done. The staff rotate. So let's say it's largely primary care that's offered during these extended hours, some OB-GYN and pediatrics as well. And so there's a team of 3 or so for each of those. So it would be every 3 weeks you would have this schedule. And to be honest with you, I was surprised. So there was a point in time, the clinic that I'm highlighting right now is a clinic that I was interim practice manager over before being over patient experience well before that. And the staff actually really liked it. I thought when I came in that this was going to be a huge problem and I was going to get a lot of pushback, but really it was something that they adapted to and were very open arms about, and they understood the reasoning too. And so that's always important, the why behind what we're doing, right? Connecting back to, there are people out there, your neighbors in your community that can't get here from 8 to 5. And here are the problems that they come across, right? And so what we're doing is we're trying to give them better access to care and make sure that they stay healthy, because otherwise they could fall by the wayside. So this is specific to adverse childhood experiences. So you remember the lady on the radio, as I was driving up here, saying opioid epidemic, high correlation to adverse childhood experiences. So these kids they're going through a lot, and then later in life they get hooked on some stuff. So what do we do to improve adverse childhood experiences? We open up a PD partial hospital. So this is a clinic that's set up for kids that need all-day care because, frankly, their families don't have anywhere else for them to go during the day. Their parents are off at work, and they don't have the resources available for babysitter or things like that, but they have high levels of physical needs, very complex physical needs. So this clinic had a full-time school teacher, nutrition, physical care, therapy, including physical therapy, social work, etc. The PD high-risk medical home provided comprehensive preventative care to high-risk children with severe chronic conditions. So the qualifications for that were listed below it. Greater than or equal to 3 ED visits, greater than or equal to 2 hospitalizations, or more than 1 ICU admission, and a 50% estimated risk of hospitalization. So in this location, they deliver primary care and specialty care, and it's shown to reduce serious illnesses and healthcare costs on children. There's actually an article we had published in JAMA. If you're curious, just let me know, and I can forward it to you, or forward it to Casey, she can share it. I don't know. The PD, I call this a PD maltreatment clinic. That's not the actual name of the clinic, because it would just not be great marketing to have maltreatment on the front of the clinic when you take your child into, right? It was called the Mary Clinic. So this one delivers care to pediatric abuse victims and children in foster care as well. So here they're getting medical care as well as behavioral health care. All of these clinics follow the 4-quadrant model for clinical integration of behavioral health and primary care. If you don't know what that is, it's a quick Google search, and it outlines, here are the 4 basically varying degrees of how integrated behavioral health truly is with your primary care practice, so that you're best serving the patients. And this is something that we partnered with payers. The ones that come to mind were Amerigroup, Community Health, and there was one more, but they actually have programs that would help with our reimbursements, so they would provide care like these. And, you know, given whatever your level is on that 4-quadrant model, have an impact on the reimbursement from those groups as well. All right, so now we're going to get down to specifics. How can I support? If I'm a provider, what can I be doing, right? Postpartum depression screenings. We would do those with pediatric visits. You know, obviously the socioeconomically disadvantaged are not always getting the care they need. It's great if they're bringing their child in. That doesn't necessarily mean that they're going and seeing their provider as well, right? So we would use that opportunity to talk to them about getting this screening done, and it was well received so long as this message went away. Lactation support. I think many of you probably already know the benefits of breastfeeding over the fake milk option. It's much more cost effective. The health benefits are extremely good both for the child and the mother. So this is something we would support and actually have lactation consultants come on site to speak with the parents. Smoking cessation. So what we did for that is smoking screenings, some smoking education, but also referring them to Quitline. Quitline is the only model that shows evidence of effectiveness for smoking cessation. So this is a toll-free hotline staffed by counselors that specialize in smoking cessation. For drug abuse prevention, we do the depression screenings, the PHQ-9, prescribe pain medication with caution, obviously. There are alternative, non-medical, but evidence-based interventions that can be used. Those include acupuncture, massage therapy, physical therapy, and even meditation. They just have to be done the right way. You obviously want to figure out who's the best in your community that you would refer to for those. And then just overall education on, particularly when it comes to that opioid conversation. We have a sickle cell clinic. These patients are in extreme amount of pain, right? And we're having to have conversations with them about why we're not prescribing opioids. So that has to be done in an educational manner, right? Where we're looking after their best interests in a preventative care sort of.
Have you ever worked with Dr. Francis?
Oh yeah, he's okay.
Just okay?
Guess who just got reinstated? Well, not officially. Nervous?
Yeah.
Yeah, me too. Don't worry about it. We'll figure it out. I'll see you in there.
Just okay is not okay.
You're the patient. What are you feeling in that moment? Yeah. Tell me this. Here's another question. Here's a more real life example. If you're a patient suffering with diabetes, you're coming in to see a new provider. You've been seeing this endocrinologist for years, but you think, you know what, maybe there's someone a little better out there that can help me out. You see someone new. They tell you this up front, right? You ask why they're coming in today, they tell you their story. Then you go about the conversation and ask them other questions. Now, how do they feel now? In other words, did we do anything to promote their confidence in us? And what I mean by that is I'm not ever saying let's brag on ourselves, right? That's not the message here. The message is, you know what? You take 2 seconds to say 2 or 3 sentences. I've worked with patients in your shoes plenty of times before. We've gotten back to very positive health outcomes. Let's do the same with you. So just that little words of affirmation to say, yes, I have confidence in you. This person's done this before. Confidence in the care provider is the #1 most correlated question when it comes to overall patient experience scores and likelihood of recommend. So if you have an opportunity to just say those really 2 sentences, that's huge. And obviously you want staff that are giving that messaging as well, right? The nurse or MA or whoever it may be to speak you up before you ever enter the room. And that's certainly something I think Casey's been working on and others as well. So. Why is the patient experience important? How would you all answer this question?
you know, I don't know if it's time for us to start talking.
Yeah.
I've done a lot of work with this, and I've worked with a couple of organizations who paid attention to this particular question. It actually changed the way that I approach patients as well. And you mentioned patient confidence in provider, but a lot of times that's related to a whole bunch of confounding factors, including concordance of provider and the patient. If it's somebody who I relate to almost initially, if it's, let's say, sex, same ethnicity, same racial background, same community, you know, then my confidence can be affected either adversely or in a pro manner based on it. But compliance is directly related to oftentimes to confidence.
Yeah.
And so patient experience is important because when they come out of the experience feeling that I was heard, I think this person knows what they're doing, I'm gonna actually, you know, go get this medicine, or I'm actually going to, you know, stop drinking 2 liters of Coke, despite the fact that I have diabetes. I had that conversation today. That type of thing helps compliance, and compliance helps our outcomes, and that's what we're really kind of pushing for.
Casey, do you have a gold star on hand? That's the perfect answer. So typically when I ask this question, the answer goes to reimbursements, referrals, like we would recommend. Don't get me wrong, these are important, obviously. They are not typically what drive our behaviors, right? Not when I'm on the ground level, when I'm the actual provider who's working with that patient or a staff member either. Another good reason, loyalty. There's some business reasons behind that, right? I want repeat business, but there's also some good clinical reasons for that, right? Continuity of care. The one that I like the most, just mentioned trust. Because if I don't have trust in my provider, do I follow through with that medication that was prescribed to me? Do I schedule the preventative care procedure that we talked about? Do I follow the treatment plan as a whole? No, those fall by the wayside. But if I have that trust, I have a good patient experience, that my likelihood of following through with the compliance, and then we're talking about better clinical outcomes, better population health, right? That is the key motivator for most of the healthcare population, faculty, staff, is we're talking about getting people healthier. We can't actually do that if we're just, you know, telling them to take this and walk out the door, right? Improve clinical outcomes. So, like I mentioned earlier, we want to target those who are at the highest risk of loneliness. Elderly, disabled, addicts, particularly opioid, where it's viewed as really criminal. And you know, sort of the list goes on here. And connect with patients, not just as customers, but as people, right? Research shows, and I'm about to show you this video, it takes 56 seconds to build what a patient would consider a meaningful relationship. And so that puts a lot of weight and importance on the first minute or two that you're in there with the patient, right? And you're actually taking some time to get to know them, what's going on in their lives. It's not just small talk. You're learning about the other 99% of their life that's influencing their health, right? The socioeconomics, the infrastructure, the physical aspects of their health. So this is a really prime opportunity to figure out what can I do to help improve this person's health when they're not here with me today, and outside of just their clinical diagnosis and clinical treatment plan. Is there something else, like maybe it's access to short-term living, right? Or maybe it's maybe they need child care, and they're really not sure where to go. When we have those resources readily available, then we can better improve not just their health or their child's health.
We've done a very good job in medicine at depersonalizing our relationships with patients, but it doesn't need to be that way.
And it actually helps you in the long run. And you know, it doesn't take that long to do it. That's always the pushback I don't have time to spend 15 minutes with every patient. Too many patients, too much to do. We've done the research. It takes 56 seconds to make a connection with a patient. And the entire conversation has never, in thousands of demonstrations in practice and in front of audiences, it has never taken longer than 2 minutes. And it completely changes the experience of the patient and for the people who are taking care of patients.
It makes your job as a caregiver and clinician far more satisfying because you can see your patient relax. You can see your patient feel safe and feel cared about. And that 56 seconds assures them that we've got your back and we're caring about you, not just about what's going on with your health.
It's such a simple message, right? 56 seconds. But I'm sure it requires a lot of work, or does it?
It doesn't require a lot of work because I can find a connection with you just by saying, you know what, Joe? When you're not in the hospital or when you're not in the doctor's office, what do you like to do? And you will tell me something about your family or your job or your hobbies, and I can find something that will let me connect with you. And then from now on, we have a lot to talk about that has nothing to do with the reason you're in care, and it changes your experience and mine.